Welcome to Barry's In the Interim podcast, where we explore the cutting edge of innovative clinical trial design for the pharmaceutical and medical industries, and so much more. Let's dive in.
All right, welcome everybody back to In the Interim, where we talk about all things clinical trial science, and I have a distinguished clinical trial scientists with me today. So I have Dr. Derek Angus, who is a distinguished professor and holds the Mitchell P. Fink Endowed Chair in Critical Care Medicine at the University of Pittsburgh. Also secondary appointments in medicine, health policy and management, clinical and translational sciences. He's been the chair of the Department of Critical Care Medicine since 2008. And since 2015, he's been the director of the UPMC ICU Services Center. He's done everything in critical care. He's in Pittsburgh in the Department of Critical Care. He's also a senior editor at JAMA. So, Derek, welcome to In the Interim.
Thank you, Scott. It's my pleasure.
Yeah, so this is a space we want to talk about all things clinical trials. And I think we have several topics we'd like to go to here. And the first topic, I think, is interesting in terms of clinical trial science and something I don't know much about, but steroids for the treatment of community-acquired pneumonia. And maybe we should set this up a little bit. My experience, and Derek and I worked together on the REMAP-CAP trial. We've worked together on multiple things. I consider Derek a very good friend. So I'll get that conflict of interest out of the way. But let's talk about steroids. So the history of steroids. It'd be better if you give this history of steroids. From CAPE COD through REMAP-CAP, what do we know about using steroids in community-acquired pneumonia, and why is it so controversial?
It kind of tires me just to think about the topic, but all right, let's. So first of all, steroids are incredibly powerful pleiotropic agents. They do all sorts of things. That broadly speaking in the space of critical illness can include dampening down the immune system and can include some potentially beneficial effects on your cardiovascular system by helping retain fluid, help improve resolution. But they're pleiotropic in that they do all sorts of things that are disadvantageous as well. Every medical student learns about all the pros and cons of prolonged steroid therapy and so forth. So they're powerful agents, they do a lot of things, and they're dirt cheap. So if they were to work and you knew how to give them, they could be incredibly advantageous worldwide in all sorts of settings. In the space of community-acquired pneumonia, so first of all, we're not necessarily talking about the pneumonia where you never come to hospital. But of all the pneumonia that gets you sick enough that you need to go to hospital, that also overlaps with getting sepsis. So if you come in with a pneumonia and you get organ dysfunction, you've effectively met the criteria for sepsis. And so when you talk about steroids for pneumonia, you're also talking about steroids for sepsis. In fact, pneumonia is the most common cause of sepsis. So there's a big literature on trying steroids in both sepsis and in pneumonia. And when you do a sepsis trial of steroids, half of the patients have pneumonia. And when you do a pneumonia trial, half of the pneumonia patients have sepsis. So they're joined at the hip. Back in the 80s, people were giving huge boluses of methylprednisone, like a gram of prednisone. And people thought that would instantaneously bring people back from the brink of otherwise dying within minutes of profound septic shock. And then a couple of big trials said, oh no, this is actually killing people. You might think that you get some temporary stabilizing effects on the cardiovascular instability, but actually that's such a huge dose, it probably causes secondary infections, etc. And so then steroids disappeared. And for a long time, people thought, yeah, steroids always help in the short term, but as best as we can tell, they're not actually helpful. And then around the turn of the century, the French, really led by Djillali Annane, started to suggest we weren't using steroids properly. And he in particular started thinking about...
And properly, does it mean the right patient or the right kind?
Yes, exactly. So he came up with... he came up with, you need to use a different formulation in a different subset of patients. So he started experimenting with effectively giving a week of hydrocortisone, not a day of methylprednisone, at a much lower dose of sort of total steroid dose. He also combined it with fludrocortisone because he argued that that would also be beneficial. And he restricted it to these really sick septic shock patients that he felt had not responded to fluids and who were so likely to die of the sepsis that you should give them steroids. That if you used a milder or broader cohort, you might accidentally give patients who weren't going to die anyway, but now you might increase the likelihood of harm with the steroids. And he particularly also said there's even a subset in whom we all make steroids, and it's a stress response hormone. And so he said you should even be doing a test to try to understand whether your own endogenous stress response is compromised. And if you can't mount a good enough internal endogenous steroid response, you would be particularly likely to respond. Bottom line is he had a spectacularly successful study. Suddenly the international guidelines were saying, oh, you should give steroids. They clearly work in sepsis. And then people started playing around with broader patient populations again, like pneumonia. They said, well, maybe the pneumonia that's particularly pro-inflammatory might benefit the most. Once you know you have antibiotics on, you should maybe also give steroids. And there were a number of studies that were sort of grumbling along, somewhat beneficial or not. But meanwhile, in the broader area of sepsis, no one could repeat Djillali's study. The Europeans tried it in something called Corticus. The international guidelines, which were published every 4 years, all through the 21st century. If you pull up the steroid section, the literature was changing slowly, but every 4 years the guidelines would be written differently depending on who was in the room, because this was what I would call an opinion-rich, data-poor environment, and people just felt. They continued to feel like everyone had their favorite study. If you wanted to give steroids, you liked the Annane study. If you didn't want to give steroids, you liked the Corticus study. So then people said, enough is enough. We need some bigger, more definitive trials. And two groups decided to do much larger trials in septic shock. And they're much bigger than any of the pneumonia trials. So I know you asked about pneumonia, but I feel like in many respects, the sepsis literature is the more dominant. So the French did another much bigger study called Approach, and it was published in the New England Journal of Medicine, and yet again, in their hands, they knocked it out of the park with a big improvement in mortality. Meanwhile, the Australians ran the trial called ADRENAL with several thousand patients, also published in the New England, no benefit from steroids. It's like, are you kidding me?
Any harm? Any harm potential from ADRENAL?
So ADRENAL didn't really show any harm overall, but one obviously wonders if the French were successful and if the entry criteria weren't exactly the same and they were recruiting a narrower subset, was ADRENAL neutral because it was including the people that just looked like the French in the Approach trial, but also including other patients that in whom there was no benefit, and one canceled the other, if that makes sense. Now, some of this is published, some of this is not published, but people have then tried to find within ADRENAL the subset of patients that looked like the patients that were in approach to see, well, is there at least some suggestion? But thus far, no one can find within the ADRENAL trial a subset that looked like approach who then have a similar effect to approach. So people are confused. Along the way, the French also did another trial called CAPE COD that looked quite like the approach trial, only it was just in pneumonia. Slightly lower severity of illness group. There, again, they showed fantastic benefit. So every trial that's run with fludrocortisone based out of France has been positive. There's a lot of collinearity there. I don't know whether it's about being French or if it's about giving fludrocortisone. No one has tested fludrocortisone outside France. And every time they tested, it's been beneficial. And then the French then also went back to approach and looked at the patients in approach, the subset of septic patients who had pneumonia. And there, too, they found most of the signal in approach appeared to be in the pneumonia patients. So CAPE COD was positive, approach was positive, and approach was most positive within the patients that had sepsis and pneumonia. So this definitely, I mean, if you were in France, if there was only the French literature, this would all be tied up with a bow on it, which is you would give steroids broadly to hospitalized pneumonia, broadly to sepsis, and you would expect the largest benefit in the patients who had sepsis due to pneumonia. And we would sort of wipe our hands and go on to one of the many other unresolved questions in critical care. But the problem is we cannot generate an evidence base outside France that goes in the same direction. There are some other pneumonia trials with non-mortal endpoints that are somewhat beneficial, but most of the positive signal is driven by these French trials. And so even when you look at meta-analyses, I would say most of that is being driven by the French experience. The French are now leading another huge consortium to study steroids, particularly in sepsis, but again, many patients will have sepsis due to pneumonia. I forget the acronym for it, but it's just been funded by the European Union and it's being led by Djillali Annane. And one of the things they're going to be trying to tease out is, well, let me step back. So I've somewhat jokingly said there's the French experience versus the rest of the world experience. Yep. But more pertinently, I think what we can say is we don't get consistent results. And across the different trials, we give the drug slightly differently and we select the patient slightly differently. We could also be giving co-interventions differently as well. We also have a slightly different duration of follow-up. You asked earlier on about harm. Steroids always run the possibility of being beneficial on the short end, but then giving steroids has some unwanted sequelae that manifest later. So it could also be the timing and the nature of the primary endpoint. So when the evidence base is consists of variable drug and dose, variable patient selection, and variable endpoint, and then you don't get a consistent result, you're left saying, okay, what's driving the inconsistency? Now, obviously, the endpoint is relatively easy to fix. In all of the different trials, you could collect multiple different endpoints and then try to measure a common endpoint across all the trials. So regardless of what was primary, if you had long enough and rich enough follow-up, you could standardize. So then let's go back to the two other plausible domains of heterogeneity. There are, I should say, before I get
let's touch on a little bit. But then there was COVID, and CAPE COD, for example, I don't think they enrolled influenza, so they stayed away from influenza. But then during COVID, recovery, REMAP-CAP showed strong benefit of steroids for the treatment of hospitalized COVID.
Yes. So, hey, it's Friday. It's Friday afternoon. What can I say? I'm not firing on all cylinders. I should totally have brought that up. That prior to COVID, we were a bit on again, off again with steroids, and we were moving increasingly towards, well, maybe in the sickest septic shock patients, in part because of the approach trial. But we'd got away from giving it more broadly in pneumonia because it just wasn't a strong enough signal. The non-COVID CAPE COD hadn't yet been published and so on. However, then during COVID, which is bad pneumonia, suddenly it looked like steroids were beneficial. And in the dexamethasone experience in recovery, the benefit was all in the sicker patients, which again, that just almost reinforces that it's not just in bacterial pneumonia. It may be in general that this sort of the severe end of this syndromic experience of getting threatened lung function from some invading daddy that then could be complicated by multiple organ failure or sepsis, regardless of whether that's driven by virus or by bacteria. It seems like steroids are really doing something. People also thought one of the advantages of COVID is that it's a much more homogeneous insult. That in some of the other trials, sometimes you can't even work out, is it pneumonia? Like a ton of pneumonia, classic pneumonia trials, many patients have no identified organism. And so one of the long-standing things was, well, you didn't even put the right patients in the trial. Whereas the COVID trials, people said, well, now these patients are in hospital for a pathogen-driven pneumonia. They're not just in hospital for a pneumonia complex that might sometimes actually just be heart failure that looks on the chest X-ray like pneumonia. And so then people sort of said, well, you definitely want to give it in COVID. And what's more, when we have a true classically selected population in whom we have very high confidence that they definitely have an infectious pneumonia, and especially when they're severely ill and getting altered, distal organ dysfunction, i.e. sepsis due to the pneumonia, we seem to get this pretty strong homogeneous sense of benefit from steroids. That's one argument. There are definitely critics of these trials, but for those who like them, they would say not only should you give steroids in COVID, but while we're at it, it's making us increasingly think maybe steroids, if you like peanuts, you love peanut butter. And so now the guidelines they've totally swung to be very positive. Current guidelines, they all differ slightly in who they say you should give it to, and even which kind of drug you should give, whether you should give hydrocortisone, prednisone, etc. But I would say, in general, guidelines from the different infectious disease and critical care societies, the WHO, etc., have all started to become much more. They're all pretty positive on steroids. Now,
okay, so we were involved in REMAP-CAP in non-COVID, where we hydrocortisone, and we were looking at stratifications of patients by shock, by influenza, yes, no. And that result showed reasonable probability of harm. It showed worse mortality in all four of those groups. We didn't have a whole lot of influenza, but it was pretty convincingly negative, 90% probability of harm in CAP, shock or not, patients. Again, a differential result to all of that.
Yeah, I hated that result. That was incredibly disappointing. So I think we would agree that trial didn't run quite as well as we would have hoped. It was an open label trial, and we had worked with sites who said that they have enough equipoise that if the patient is randomized to control, they would be happy not to give steroids. But there was bleeding of steroid use into the control arm. It wasn't massive, but you never know whether, if it's random bleeding, it probably doesn't matter too much. It's just slightly weakening any efficacy signal. But if the physicians have some magic inside track on knowing just exactly who they should treat, then you could imagine that any signal you would have found is getting wiped out by contamination. Having said that, I don't think so I wish there hadn't been that steroid use in the control arm, but the steroid use in the control arm wouldn't explain the almost hitting the harm signal. Like, steroid use in the control arm if steroids would have normally worked, all it would have done is reduce the size of the benefit. It wouldn't have flipped it in the wrong direction. Now, obviously, as you start to get smaller sample size, some of this is just sort of random error and so forth. But that, it made me slightly uncomfortable. We also, as you know, we had there was a transposition error by one of our data vendors early on in the trial that sent us a data set that had been mislabeled. We as soon as we found that out, we sort of fixed it all, and they're no longer a data vendor even in the trial. But that did mean that there was a period when we were probably randomizing with a more distorted sort of response adaptive. The response adaptive randomization triggered a more aggressive randomization away from what would have been ideal. And again, the main consequence there was probably, we had several hundred patients in this analysis, but they weren't evenly distributed. We would have had more power if it was more of a one-to-one distribution. And so that, again, just introduces another level of uncertainty. But what I don't want to lose in any of that is while none of these things were ideal, we were a long way from looking anything like the CAPE COD experience.
Yeah.
In other words, no matter how much you subsetted the trial, no matter how much you tried to for example, in the early part of the trial, before there was any response adaptive randomization whatsoever, when this was just like a straight head-to-head traditional one-to-one trial, even there, the trend that the patients getting steroids, their outcome, the observed outcome rate was worse. So is it all just the play of chance? Possible. But to your point, the probability statements, nonetheless, would say that even accounting for chance, it's just highly unlikely that that steroids were strongly beneficial. I want to remind people that the ADRENAL trial with 4,000 patients found no benefit. So it's not as if REMAP-CAP was an outlier. REMAP-CAP, in many ways, was one more trial consistent with the many trials that have not actually found a benefit. And earlier on, you had asked about harm. There was, like the big European Cordicus trial, they had thought that patients appeared to get slightly faster resolution of shock. And by the way, in REMAP-CAP, it looked like the observed rate of cardiovascular dysfunction appeared to resolve sooner. That was also what the ADRENAL trial found, that the early short-term cardiovascular instability resolved sooner. But in Cordicus, where they had done follow-up on secondary infections which steroids can cause, were higher. There was a higher nosocomial infection rate in the steroid arm. And it is possible that something was going on in REMAP-CAP where we might have actually been getting some of the early cardiovascular benefits, but the net effect for the cohort in general was that steroids were worse. And so now we get back to Can you better pick
Okay,
the
so
patients?
yes. Right. So one of the things that was sort of striking in the REMAP-CAP trial is that mortality was against steroids, but organ support-free days, which includes mortality, but it includes time to resolution of organ support, actually was better on the steroid arm, despite the fact that mortality was worse. It has the earmark of another particular disease that was somewhat striking, is the treatment of acute stroke, where early on in the treatment of acute stroke and the use of endovascular therapy, they saw this non-proportional effect, that they certainly improved the number of really good outcomes. They certainly increased that, but they increased the number of deaths. And it was a sign that there's differential heterogeneous treatment effect. They were probably treating people they should not treat, and they were causing harm on those. And they were treating some that they absolutely benefited. And it took a while before they kind of figured the right patients, and then they saw huge benefits in that. So the steroids has this hallmark of heterogeneous effect across the population. And I know you touched on, maybe it's the infection, maybe it's the host, maybe it's the timing of the disease, maybe it's the steroid themselves, dexamethasone, prednisone, the type of that. There's so much here. So it's got the earmarks of heterogeneity. So, should we be running trials that we enroll 1,000 patients and do a single analysis of, is it beneficial? Do we need better trials? So let's sort of turn it to, where do we go? And if you could design the right trial, you seem to not know which patients, which treatments, which time, shock-based therapy, a 7-day dosing. Where would we go if we could fund the right trial? What's the right trial design?
Yeah. So I would love to talk about that, but can I just ask,
Okay.
just make a clarifying.
Okay.
So when you have the organ failure free days, if you died, any effect on your organ dysfunction is sort of subsumed within the fact that you died. But you did allude to this all being explainable by the right patient. But it is possible with some of these early versus late outcomes that it's just the timing of the measurement, even within an individual patient. That wouldn't be the case when it's organ failure free days, because if you died, you're dead. But we know in critical care, for example, low tidal volumes, which is a strategy of ventilating the patient in a way very differently from the way that we did for decades, would almost certainly make the patient look bluer, more hypoxic in the short run, because greater expansion of the lungs actually facilitates gas exchange. You get better oxygenation. But it turned out that the low tidal volumes absolutely protected the lung and improved survival. And so high tidal volumes makes you look better in the short run, but then kills you. And
Okay.
and with all of these interventions, when we move into these combined endpoints, do so at our peril, because they do tend to rely on conceptual models that could be wrong about whether the intermediate outcome is on the path to greatness. You would think a short-term measure to improve organ dysfunction is surely helping you get out alive. But the answer is not so fast. So that's one issue. But assuming we've got the outcome right, and the problem is heterogeneous patients, and you don't know which ones they are. This is a classic issue. So I feel like there were always what I would call the hope and pray models, which is what everyone did before, which is you just enroll everyone and hope that you got the right group, or that if there's a bad group, it's not so bad, it doesn't drag it down, and all the rest of it. And then we wanted to start having smarter trials. If you have the luxury of doing many sequential trials, you could always do one large trial, see a group in whom you thought there was a benefit, and then do a follow-up trial in just that group. even there, you don't necessarily prove that there's heterogeneity. That was, I remember, I think it was the editorialist very astutely pointed out that huge Jupiter trial in the New England, when they were treating acute myocardial infarction patients with some sort of anti-inflammatory strategy, just in those with a high CRP, the authors then said, oh, look, we improved outcomes showing the inflammation hypothesis and so forth in myocardial infarction. Yeah. And in the editorial, they said, for that to be true, you would have had to have enrolled both the inflamed and the non-inflamed, and showed that the drug worked differentially. You only showed that in the inflamed that the drug worked, but you haven't ruled out that the drug could have been working in the other group. Yep. If we don't really have the luxury to do lots of sequential trials, but want to be learning within one trial, then we can do a couple of things. As you know, in REMAP-CAP, we've tended to have these a priori subgroups that you, if you think you have a rough sense of where the domains of heterogeneity may lie across both the axis and where the cut point in the axis might be, then you could start a trial with some embedded rules to then effectively enrich over time. You can also do it in the other direction. You could de-enrich. You could start with the subgroup that you think it works best in, and as long as you're getting a benefit, then you could then widen your entry criteria for a broader set later. I think those kind of trials still rely on confident science or hubris about whether you actually understand the axes of heterogeneity. And so that's
doesn't this now demand a different approach where the amount of people you're caring for in critical care that have sepsis, CAP, moderate disease, severe disease, that we enroll a very large population and try to learn yes, no, in whom?
Yes. So this is where so let's step back for a second. So we are, first of all, you would say we're committed to cause and effect. We're not really interested in association. We want to know if something works. But what we've done is we've begun, an RCT tells you if something works, but it doesn't, but it's like causality with a small c. Causality with a big C is why does it work? And in a way, heterogeneity of treatment effect is more Judah Pearl-esque, if you like. It's more getting at not just explaining if the drug worked, but why the drug worked. In fact, I think it was one of Judah Pearl's postdocs, Elias Barenboim, I think, who started using Judah Pearl's sort of causal inference language to try to understand generalizability in RCTs. If you understood why, effectively, if you understood all of the moderating and mitigating effects between the covariate structure of who was enrolled and what the intervention was, then in a way, from one trial, you could predict exactly what the outcome would be in another trial, even if it was a slightly different patient population. You tell me the admixture of patients, and I will tell you the likely mean effect. What you're effectively doing is you're saying, I understand the relationship between the baseline variables and the randomly exposed intervention, and I'll tell you what the effect could be. The problem here is you quite quickly run out of sample size. I mean, there's no real magic around. I mean, in the ideal world, you could imagine every time you were faced with a clinical decision around which there was reasonable uncertainty, then you would almost want to be randomizing among the best options. So if the entire trial experience was like a huge reinforcement learning problem, where you were sitting in some Markov state, where you had a current of the world, where when a patient came into a particular state, based on the covariate structure, among all the different actions that could be taken, you would have, a probability of the eventual best outcome, rank ordered for all the different options. And of the 30 treatments you could have given, it turns out that there's 2 or 3 that all look reasonable, but they're all quite close. And then you could say, okay, every time I see this, it's reasonable to randomize to any of those 2 or 3 options, but it's unreasonable to randomize to the other 27. And then you could imagine if hundreds and hundreds and hundreds of ICUs, for example, were all contributing to this ongoing reinforcement learning model, that this state could be a known state for the agent being the collective body watching the accumulation of knowledge until, say, several hundred patients have gone through. And then at that point, you could update the probabilities, and it would turn out, oh, remember how we said there were 3 choices that looked reasonable when you were in this state? Turns out one of them is a dud, and now we're down to 2. So you would essentially, you'd move into a new state where you had sort of updated probabilities, and you would run that. And you could imagine that that's really, this notion of these freestanding RCTs that give these single estimates of a patient population with an average effect for a single drug at a single dose. That seems a total misrepresentation of the degree of uncertainty in which we exist. And it's failing to leverage all of the uncertain clinical decisions that are made in regular care. And so in a perfect world, and I am massively leaping over all sorts of issues about research versus clinical care, the Belmont report, etc. But assuming you had the right ethical framework for this, assuming that everyone was read in on this, that they all approved, you could imagine a large federated set of learning health systems where all of their electronic records are all sort of wired together, and you have some sort of asynchronous API that could sort of read-write commands that was able to stream the information so that just at the moment that the clinician was encountering the patient and faced with uncertainty, you could then pull from the data, what this moment looks like is it's a patient with the following baseline characteristics about whom we have uncertainty on the right option. And so that's like a mini part, it's like a mini randomization question. And then if people understood, yes, there's legitimate uncertainty, and it's within the bounds of reasonableness to randomly choose what treatment to take, or even to randomly make a recommendation. I mean, you could still, if you want, you could still say the patient and the physician are allowed to override the recommendation. And if they did that a lot, then the trial is getting contaminated. But if it turns out that they say, oh, that's not an unreasonable suggestion, we're both happy with that. If that was happening 99% of the time, then effectively you're running these huge, large, embedded, ongoing randomizations. And if it turns out that among all of pneumonia and sepsis, there are 1,000 different phenotypes, all with, and some of them cluster into net benefit, some of the net harm, etc. We could be learning about them over time. These diseases are common. Anyways, have I got way too far out over my skis?
Well, no, let's see where you got that. Currently, right now, we're not learning from any of these patients.
No,
they're being
that's right.
treated. They're and so now we're going to tie this all together. We're going to embed randomization, and we're going to favor randomization of treatments that are working. So we're going to care for those patients better. But it would give us the possibility of learning about heterogeneous treatment effects, the signatures that benefit this. We're going to enroll thousands of patients in this common disease. You've described a learning healthcare system. And maybe in the world of AI, maybe the thought is, okay, AI is now deciding what to give. It's learning from it. It's reinforcing it. I mean, this is the future, and we kind of wonder why it's not now. But I love where you've gotten. So we've gotten from these randomized trials that are showing differential effect from steroids to a learning healthcare system. And I want to come back and talk about that because I think that's more than just a idea. I think we have some really great hopes of embedded randomization learning healthcare system. Call it AI, call it modeling underneath that is pretty exciting. So, Derek, I'm thrilled that you were able to join us here in the interim. We do lots of interim analysis here, so we're gonna have you back to talk about this, to talk about learning healthcare systems, and maybe we'll have resolution about steroids in sepsis and CAP.
We can only hope.
All right, so thank you, Derek, for joining us here in the interim.
Thank you so much, Scott.